PK, I want to really say it's great to be back here. It's great to be live and in person, and so it's kudos to you for pulling off this.
Welcome to New York. We're so happy to have you back.
I'm thrilled to be here. Believe me. So I'm going to talk about my algorithm for definitive therapy in severely calcified SFAs, DES, BMS, DCB, as well as some adjuncts that I think are very helpful for these types of cases. So obviously, as I mentioned just a few minutes ago, I think there's two modes of failure in the SFA. One is biologic restenosis, and the other are residual mechanical forces. And luckily, we have a few devices to deal with the former, the biologic restenosis with DCBs and drug-eluting stents. In terms of mechanical forces that are left behind on the vessel, these could include things like dissections, but really we're mostly concerned about residual plaque burden, and specifically calcified plaque is the real challenge, I think. And in dealing with calcium, I think there are basically three ways to deal with it. The most intuitive is, of course, to put a scaffold or a stent to basically prop that artery open. There are some other options and adjuncts that I'll go over as well, breaking it up in some way, shattering the plaque, the calcium, or actually removing it in some fashion. And so I'll go over some adjuncts to stenting that will help with some of these different strategies. So in terms of stents or scaffolds, if you're going to use a scaffold for calcium, then the real requirement is that scaffold has to have sufficient crush resistance or outward radial force, really more crush resistance, so that it can withstand that calcium. And there's a few different options for stenting now. We previously only had laser cut nitinol stents, and so these are stents that are cut out of nitinol tubes, shown over here on the far right panel. And essentially, these tend to want to retain a rigid, straight sort of structure. And that contrasts quite a bit from the Supera stent, which is an interwoven nitinol stent. And I think those of you who've used this, and as you saw in the case by John just a few moments ago, these scaffolds and stents they have some properties that really help them be very advantageous in severe calcium. The stent's made up of basically 6 woven nitinol wires that are connected only at the end, and it has some flexibility and some crush resistance that's very unique. The results of this stent in the SUPERB trial, which is the IDE trial for Supera, are really exceptional, especially in those scaffolds that were deployed to the nominal length. So these can be compressed or elongated, and you don't really want either of those scenarios. You want them to really be deployed at their nominal length, and those stents that were deployed to that nominal degree or nominal length had a 90.5% primary patency in the SUPERB trial. So these are really outstanding results for an SFA stents. Freedom from TLR in the SUPERB trial was sustained all the way up to 3 years at 94% for those that were deployed well. So incredible degree of primary patency for this stent. The other thing that's interesting about this stent is that unlike many stents, the longer the lesion, we don't seem to see a drop-off in primary patency. So these are a number of the published trials, published trial and peer-reviewed manuscripts for the Supera stent. And as you can see, when we go from the 5.3 centimeter mean lesion length all the way up to 28 centimeter, all of the patency rates are in the similar range of 80 to 90%. And so this is unlike most stents in terms of a patency that's independent of lesion length. But probably the most relevant for this talk is this feature here. The majority of the patients in the SUPERB trial had either moderate or severe calcification, and 45% of these patients were deemed to have what was considered severe calcification. And the primary patency in this subgroup is 89% compared to the overall primary patency in the entire trial of 86%. So this suggests that even with severe calcium, which was present in almost half of these patients, there's really no change in primary patency. And the reason for this, I think, is shown here. On this graph, you can see at the bottom here are all standard laser cut nitinol stents cut out of nitinol tubes. And the Supera stent has about 4 times the crush resistance of these other stents. And I think this explains why this holds up so well in calcium. So I think this is probably, in my opinion, the most effective strategy at really tough calcium. And that's why I use it in my practice. Now, what about drug elution? So I mentioned the issue of biologic restenosis, and certainly we've sort of evolved to using drug in most of our cases. The intuitive sort of pathway for dealing with both of these issues is to use a device that not only provides a scaffold, but also then provides drug to prevent restenosis over time. And of course, there's 2 devices on the market that are combination devices in this manner. There's the Zilver PTX stent and the Illuvia stent. And the Illuvia Imperial trial was basically a 2-to-1 randomization of, I think, 465 patients, 2-to-1 randomization to either Illuvia or Zilver PTX evaluate these two different devices. The concept behind Eluvia is that because there's a polymer that helps to elute the drug over time, you get a more prolonged effect of that drug elution compared to the Zilver stent, in which you get a very high amount of drug early on, and that tapers off very quickly, almost analogous to our DCBs. The 12-month results are shown here. Eluvia had an 88.5% compared to 79.5%, and even though this was designed as a non-inferiority trial, there was enough of a difference here to actually show superiority for the Eluvia stent. So I think this is really a very good stent for the SFA in general, and I think this is an attractive strategy for dealing with calcium and preventing the biologic restenosis. Now, the problem with this stent, as well as all laser cut stents, as I alluded to in my discussion of Supera, is that there's properties that come with a stent that's cut out of a laser cut tube that make it a little bit disadvantageous in areas of high torsion or flexibility, or areas that are heavily calcified. So these just simply do not have the same radial force or crush resistance as something like a woven nitinol stent. And you can see this in IVUS images where you have calcium on the outside of your stent, and you see the stent often getting crushed in a sort of oblong shape. And so I'd see that the problem with this strategy of using a laser cut nitinol stent with or without drug is that, first of all, if you're going to use these to elicit drug, you're going to cover the entire lesion length with scaffold. And we've kind of moved away from doing that in general. The issue is that these stents don't have the same crush resistance. So how could we get a little better results with these type of devices? Well, the sort of logical progression is to take these devices in combination with something else that will help modify or change the nature of that calcium. And that's where I think intravascular lithotripsy or shockwave balloon is actually a very attractive strategy. This is a device, it's a balloon with a series of emitters on it that will basically send out lithotripsy energy to break up and fragment this calcium. And in Fabrizio Finelli's talk, he showed that one image where you had circumferential calcification, and then after IVL, you had a crack in the calcification. And that's what allows you to really expand these vessels well after intravascular lithotripsy. So I think this is a device that is sort of, we're growing our experience with it as we speak. There's been a number of different studies. The one randomized controlled trial, Disrupt 3 PAD randomized controlled trial, has been reported and in a peer-reviewed manuscript at this point, only a few months ago, back in June. But this was only 30-day outcomes, and these 30-day outcomes did show to those patients randomized to IVL, they had an increased procedural success at 30 days, same degree of residual stenosis as those patients treated with PTA, albeit with fewer need for fewer stents. So I think that the long-term results of this will be interesting, and I think we kind of have to excuse me wait and see what the long-term data is like. But I do think this is an attractive sort of direction to move into as a combination therapy. So what about DCBs? DCBs certainly deal with the biologic restenosis. We've incorporated these very heavily into our practices. The one problem with these, of course, is that they don't deal with any mechanical forces that are left behind in the vessel. One of the other problems is that they have not been studied very well in calcium. So if you look at all of the IDE trials that have gained approval for these devices, generally less than 10 or 15% of these patients had any significant degree of calcification. So they really have not been studied very well in calcium. For those studies that have reported the results of these devices in calcium, like Fabrizio Finelli's study shown here, he's found, and others have found, that as we get an increased degree of calcification, especially circumferential calcification, we tend to have reduced patency and increased late lumen loss. And so the available evidence that we do have suggests that these devices, while they work well in soft lesions, they do not work as well in calcified lesions. And this could be simply because of the residual mechanical effects of the calcium on the vessel, or because of issues with drug delivery and drug uptake. So an attractive strategy here, I would say, is removing this calcium or modifying this calcium in some way to debulk the residual mechanical forces and to hopefully allow better drug uptake. We looked at this in the reality trial, and this was designed to basically look at the toughest of the tough lesions, so long calcified lesions, because we felt that these were the lesions most likely to benefit from this combination strategy. So in this trial, we aimed for lesion lengths of 8 to 36 centimeters, long total occlusions, And to be enrolled in this trial, you had to have bilateral calcification in the lesion. And so it was unilateral calcification or non-circumferential calcification was not adequate. It had to really have bilateral calcification. And the total mean lesion length in this, or the mean lesion length in this trial was about 18 centimeters. So we clearly got lesions that were longer than any of our IDE trials for different devices. And if you look at the PAX index, which is basically a ratio of the total bilateral calcification to the lesion length, it was over 50% basically, which means that most of these patients, or over 50% of these patients, had calcification on a greater than half of the entire lesion length. So truly very calcified, truly very long lesions. This is a result of this, as you already had seen earlier, 76.7% primary patency for these patients in these very, very tough lesions. And if you compare this to other DCB trials, you can see that reality is really an outlier in terms of the lesion length and the degree of calcification, yet still pretty good or compelling outcomes. This bench model study may show some of the reason why we've had good results with this combination therapy of atherectomy and DCB. This is again, it's a experimental model in which cadaveric limbs were treated with orbital atherectomy followed by DCB, and it showed that those patients treated with orbital atherectomy had higher degree of paclitaxel absorption as well as deeper absorption into the tissues. And so this is evidence that maybe we truly are modifying the plaque in some way to allow better drug absorption. So this is my general algorithm for severely calcified SFAs. I think that for focal or moderate calcification, I think this combination strategy of a couple of these devices is probably a good way to go. For intimal calcification or luminal calcification, where you can really get to that calcification with an excisional atherectomy standpoint or even orbital atherectomy, then I think orbital atherectomy plus DCB without a scaffold is probably a great way to go, and that's generally my preference. For more medial or circumferential calcification, where you have deeper layers of calcification, I think this is where shockwave is potentially very valuable. And these probably will require some type of scaffold as well. So that's where IVL and DES make sense to me. For those patients that have just extremely severe long segment calcification, where I do not think I'll be able to even pass catheters like the IVL catheter or an atherectomy catheter, this is where I go simply to an interwoven nitinol stent, aggressive balloon dilatation, and using a Supera stent. So I won't belabor this anymore because I'm over time, but I'd say that calcium is a significant barrier to probably drug elution and long-term patency. I do think that to have a good result with the scaffold, you have to have great crush resistance. And for those patients who have less severe calcification, I think a combination strategy with one of these devices is a great idea. Thanks.
Thank you very much. Thank you, Brian. That was really awesome. Just any questions from the audience, because part of the goal of this is really interact with you, all of you, and find out any questions. I know the case didn't match our lectures, but sometimes that's what happens with live cases. So any questions?
When do you use cutting balloons?
Okay, so there's a good question here for anybody. Maybe Dr. Bianchi, when do you use cutting balloon?
Not primarily. I think for restenosis, probably. Early restenosis particularly. Hyperplasia, but not for native disease.
I like to use it for non-dilatable lesions that have low amounts of calcium in them because the balloon's easily ruptured. So I think that's its niche.
So Brian, just a question I think that I want to bring up. I mean, you did a great, overview of that. But so how do you assess where the calcium is? I love that end where you put it together, which kind of really is intuitive. But clinically, how are you assessing where the calcium is so you can go down your algorithm?
Yeah, so I think the first thing I'll say, sometimes you could look at it and see this is never going to work with atherectomy, and those are the ones that I go to Supera for. On the other hand, for those lesions that seem like you have a rim of calcium on the outside, but you seem like you have a hollow core, those are ones that I think shockwave is pretty good for. But I would say for those lesions where you have scattered skip areas of calcification that seem more luminal, those are the ones I use excisional or sometimes orbital atherectomy on.
Okay, Dr. Jenkins?
Not to change the topic, but just to make a comment on a common femoral peripheral intervention. I tend to leave nothing behind because of our conversations we had mentioned. So in that case, I would have probably preferred to put a drug-eluting balloon after I'd done atherectomy. And if I had no elastic recoil after watching it for 10 minutes, then I would try to leave nothing behind and not put a stent in it. Otherwise, I have no problems. I've been reaccessing stents for
Mm.
28 years that I've been at Ochsner. So
I would also echo that, just because I mean, I do think that Kundalisa data is pretty good, and I do think there's a growing role for Supera stents in the common femoral. But you also got to remember, when things fail, you got to figure out what your backup plan is. And if you have stents that fail in the SFA, doing a FemPop is not a big deal at all. On the other hand, I mean, that's attendant risks and complications. But on the other hand, if you have a Supera stent or any stent that is occluded in the common femoral, now you're doing a retroperitoneal incision to get up to the external iliac or the common iliac, and that's a very different operation. And so that's why I also agree that with a sort of a leave nothing behind strategy in general, but even more so with the common femoral.
And again, addressing the profunda as, in my opinion, the more liable, component of this high-risk procedure, although technically feasible, is a high-risk procedure because the complications are quite threatening to the limb. And the profunda is the lifeline. That previous case was a single vessel runoff, so I think both are actually quite a high-risk procedure itself. So stratifying that and having an option that is fairly simple and with low morbidity, you need to weigh those two before you make that commitment.
We have another question here.
Yeah, 2 questions. Could you guys compare and contrast Eluvia versus Zilver PTX versus Supera stents, and also like directional atherectomies? Any place for Phoenix device and the other devices?
Well, so let me ask Srini to take the first question, Eluvia versus Zilver.
Yeah, I mean, I think the data is a little bit better on the Eluvia with the head-to-head, but Zilver is not a bad option. I don't think there's a hard, fast, data-driven rule that says you have to use Eluvia over Zilver. At least that's my opinion. So I think you take your choice on which one you like better. I tend to use Eluvia, but that's me. I'd love to hear what the other people have to say about it. And regarding what Christian said about common femoral artery disease, and my surgical colleagues tell me this all the time, it's very rarely isolated to the CFA. It always extends into the proximal SFA and even the origin and proximal aspect of the profunda. And I think that's where endarterectomy does so well, because you clean out not only the CFA, but the proximal SFA if you're able to, and the proximal profunda as well. Wouldn't you guys say?
Yeah.
I think Brian alluded to the Eluvia very well in his lecture. So he showed
Yeah.
the data slide.
I mean, we don't have a lot. Unfortunately, we don't have a lot of head-to-head trials on things, and so the question of DES versus Supera, I'd love to see that trial, quite honestly, because I don't know which one of those works better. I know I have my biases, but in terms of the DES versus drug-coated versus drug-eluting stents, this is one place where we have a randomized trial that showed a difference between the two, and so that's why I think Eluvia at least has better data than
Yeah,
Zilver.
and at least in a head-to-head at 1 year. I just want to take the Phoenix atherectomy question on. I think that directional atherectomy, Phoenix atherectomy, laser atherectomy, Rotarex, whatever it is that you want to use, I think it's important for you to understand the devices and see both the strengths and the limitations of all the devices. I think all atherectomy devices are quite effective at what they do. Some may give you a better luminal gain, some may not. So some may have aspiration associated it, but I think so. It's important. So I mean, obviously in our world, very few of us have every toy in the bag. So you kind of have to go with who you trained and talk to everybody. So to create an algorithm just for atherectomy devices is very, very difficult. But I will say that atherectomy, I think, is proven very clearly to be an adjunct, not a final therapy. I think the final therapies are very clear right now. It's either drug-coated balloon or drug-eluting stents in the femoral popliteal segment. So I think that's probably the best way to answer that question.